I'm coming from Thun. This is a smaller city and just a medium-sized hospital in this direction near the mountains, so it's very nice. And what I do is we don't do much studies, we don't do much scientific work, so we just do our examinations. And the topic I talk about is detection and characterization. And when we talk about the detection of focal liver lesions in non-cirrhotic patients, we talk about the late phase mainly. So we inject our contrast agent and we look for black holes. That might just sound very easy, but there are some tricks. You see, there is nothing in this liver, so we don't have any metastasis visible. And when we have metastasis, you see very clearly these black holes, and sometimes they are not visible in grayscale sonography, and sometimes they are visible. It's much easier to see a black hole than this small lesion here. You see, it helps a lot if you wait until the late phase, 2 minutes for example, and you look for black holes. But some of these lesions are invisible. So for detection, you have really to look at these washout areas. And when you have a washout area and you don't know how the wash-in was, you do a second injection, you do just a washout, wash-in phase, and you see there is a wash-in, and this can be important to make sure that it is a really a viable tumor in the liver. And in the follow-up, you see maybe it's a bit bigger or just a little bit smaller. You can measure it very clearly in the late phase. And again, you do a washout, wash-in phase just to prove that there is viable tissue in this metastasis. If you have a liver cyst, this is quite easy also with grayscale sonography. But after ablative therapy, for example, when you have a scar and you don't see anything in grayscale sonography and you see suddenly something in the late phase, of course you have to do a wash-in phase just to prove that this is a scar and not a viable tumor. Of course, you can see these metastases also in the arterial phase, like here. But you have to be aware when you want to measure all these metastases, it's better to wait to the late phase when you see very clearly the borders, the markings of these metastases. And in the follow-up, same patient, you see there's something like a Klatskin-like tumor in here. You don't see much in grayscale sonography. So again, you make your wash-in, wash-out, and you look. You don't need a second dose in this patient. You see the wash-in, wash-out, but to measure and to look at the size and where these metastases are, it's better to do this in the late phase, like in this patient. You see very clearly these are metastases. This is a metastasis of a breast cancer. You see in grayscale sonography, here is the metastasis, same patient, same liver. This metastasis is invisible, so you need the late phase clearly to look for metastasis in non-cirrhotic livers mainly. Now let's do characterization. What you saw is an echo-poor lesion in an echo-rich liver, and you see very clearly this rapid filling from outside to inside. Nodular enhancement, rim enhancement, so no washout. This is a hemangioma. This is another case, echo-rich lesion in an echo-poor liver. You see wash-in, wash-out, clearly proven this is a metastasis. Another patient, you see not very good, but you see that there is a liver lesion, wash-in, wash-out, so this is clear. This is another situation. You don't know really what this is. Again, you see an echo-poor lesion, not well defined in an echo-rich liver. You inject your contrast agent and you see this is a hemangioma, nothing else. So you can wait until 2 minutes, maybe no washout. So this is proven not a malignant situation. This is a hemangioma. And this looks quite strange. You see there is a focal liver lesion, echo poor. Around this lesion you see another echo poor area, and then you see an echo rich liver. And after injection of your contrast agent, you see, yes, this is a hemangioma, looks like a hemangioma. Then you see something strange here. And that's what we talked about or tried to talk about yesterday about arterioportal fistulation. So this is arterioportal fistulation leading the fat poor arterial blood pushes out the fat from the portal venous system. So you have less fat in this area, so it's echo poor. You see this? This is echo poor, and you can prove this with your contrast enhanced ultrasound. You have fistulation with arterial blood pushing out the fat rich blood from the portal venous system. And this again, you see, this is not a benign tumor, this is a metastasis with huge arterioportal fistulation, and when you measure the size in this situation, it's much too big. So you wait to the late phase. You can even use your grayscale sonography just to look at the real size of such a lesion, arterioportal fistulation. Again, you see small lesion, again a hemangioma, but look at this. You see, this is an early filling of this region here, where you see it's a little bit echo poorer because it has less fat there, and you see an early filling here. This is arterioportal fistulation. Don't mistake this for some tumor or some malignancy or whatsoever. This is normal liver tissue with an early filling, with an early arterial filling. And of course, no washout. We talked about this also yesterday. This is a cholangiocellular carcinoma, and this, of course, has arterioportal fistulation. And what you see here is just something like a rising sun. It's getting bigger and bigger and bigger. You can wait until the washout, and then you do a second injection and you see it even more clearly. You see, this is the real size of the tumor, and this seems to be much bigger, but it's not much bigger. They are just arterioportal fistulation. And as you all know, cholangiocellular carcinoma have some specific vascular pattern. There are some vessels, liver vessels, going through the tumor without any disturbance. So why is this like this? Maybe it's, again, because you have arterioportal fistulation. So you have a tumor cell, and you have a tumor that grows, and then you have early arterioportal fistulation. So you have these tumor metastases around the first tumor, and more, but the vessels may be preserved. So this is a possible explanation why you have this specific pattern in cholangiocellular carcinoma, where the vessels run through this tumor. This is another situation. You see maybe 1, 2, maybe 3 focal liver lesions. You inject your contrast agent, and you see it's just there are 2 hemangiomas and nothing else. So this is very easy, and you can normally in the first few seconds you can make your decision that this is not a malignant situation. It's just a hemangioma. And look, this nice guy here, what does he wants to say to us? He just wants to say, I'm a hemangioma, I'm not dangerous. So and here you see an echo-rich lesion with sharp markings, and you think maybe it's a hemangioma, but you have seen the arterial phase. It's not a hemangioma, it's a washout. It is a metastasis of a colon carcinoma. Again, Another patient, same situation, and you have a vessel running through. We talked about this yesterday. Hemangiomas never have a vessel running through the hemangioma, and here you see this is clearly a metastasis. This looks like, I don't know, maybe a hemangioma, maybe not, but after injection of a contrast agent, you can see clearly a hemangioma, so you don't have to do anything else. This is another situation. You have a tumor in the liver and you have a specific vascular pattern, spoke wheel pattern, you see this? And you can even do this reconstruction with this machine. But be careful, there sometimes you can have hepatocellular carcinomas mimicking FNH. This is an FNH, so you probably should inject your contrast agent just to prove that this is a FNH and not something else. Maybe in a HCC you could see some chaotic vascular architecture. Here not. In a FNH not. This is another FNH. You see clearly filling from inside to outside. Spoke wheel pattern. You see the scar, the central scar, everything. And if you have a situation, this looks quite similar, but you see a totally different contrast behavior. This is a metastasis and this is a focal nodular hyperplasia. And what is specific also for these focal nodular hyperplasias, you have an early filling of adjacent veins. You see here? Early filling of adjacent veins. This is very specific also for this FNH. And you can do this several techniques like this SMI in contrast mode. Again, you see specific vascular pattern, spoke wheel pattern, and what you want to know is how is the whole also this early filling of these liver veins. So when you see this, you can be very sure this is a FNH and nothing else. And you can do it with color, whatever you want. These machines offer almost everything. This looks like a big tumor. You don't know anything about this patient. You just inject your contrast agent and you look what happens. And fortunately, it happens that this is a huge hemangioma. It looks like some maybe malignant tumor, but it is not. It's just a hemangioma, no washout, just this peripheral rim enhancement, this nodular rim enhancement. And to show you the potency of this method, I'm going to show you this case, a man with a colon cancer, follow-up examination, and you see this small lesion. You see here, this is 1 centimeter, so this is a very small lesion. And we look at the wash-in, wash-out phase. The wash-in phase, yes, there is some wash-in, but it's difficult. And yes, there is some wash-out. Maybe there are 2 lesions, very, very small. So what we do, the oncologist said, oh, I don't know, maybe we just do a follow-up examination. 2 or 3 months later, it's a bit larger. And again, you have a wash-in, more clearly seen here, and a washout. These lesions become bigger. So this is February, and now we have a CT scan just a few weeks later because the patient had a hematoma here, had pain. This is the hematoma, and the CT scan said there is nothing. And they looked specifically on this region and they said it's nothing. So we do again a follow-up examination because the oncologist said when CT scan shows nothing, it is nothing. And you see, now it seems very large. But when you look what I told you before, when you look at this contrast behavior, you see a lot of arterioportal fistulation. So it's not this size, the tumor, it's this size. And this makes it difficult for the biopsy. So what you have to do, you have to look exactly where is the washout area, and then you do your biopsy exactly where the washout area has been, and you see this is a metastasis of this colon cancer. You can also have this kind of tumor in non-cirrhotic livers. You have seen this is a very specific vascular pattern of an HCC. You see strong vessels from outside to inside. You see a chaotic vascular architecture, and you see a late washout. So you can say this is probably a hepatocellular carcinoma, and again you can see with this technique this chaotic vascular architecture with these large vessels coming from outside to inside. And what you also can see, this is a malignant portal venous thrombosis. Have you seen? You see the thrombosis here, and you see how it fills. And you can see the direction of the blood. It's going from inside to outside, out of the liver, because you have a malignant tumor, a HCC, with an invasion of the portal venous system. And this again, this is what I've shown you, a CCC, a cholangiocellular carcinoma, again with this fistulation, as I've shown you. And this is an interesting case. You see here dilated bile ducts, and you have a tumor here, and you have echo-rich liver here and the echo-poor liver here, and you have to explain why is this part of the liver echo-poor and this part is echo-rich. And because you have a biliary fibrosis, because you have a compression of this biliary, of these bile ducts, so you have an early arterial filling because you have compromised portal venous blood flow in this region. You wait, of course, you see this is the tumor, you wait to the late phase, and of course you can do a washout, wash in, if you like, and you can look at this for a second time. So it's very nice to explain some things with your knowledge of pathophysiology. This looks maybe like, I don't know, an abscess, something. It's maybe in the liver, maybe in between the kidney and the liver, but what is astonishing, you have an enhancement in the liver tissue. But an abscess would look like this. So this is not an abscess. You see? It's totally different. So what could be the reason for this enhancement in the liver tissue? So it's a hematoma. I can tell you it's a hematoma, and the hematoma makes a compression on your portal venous system, and then you have a compensatory increase in the arterial supply, and you have an enhancement of the liver tissue. It has nothing to do with a liver damage, tumor, infection, something. It's just a compression of the portal venous system. This again, this is a laceration, and you see very clearly around this hematoma, you have an enhancement of the liver tissue. And this is a very interesting case. You see, we have some calcification here and a cyst. But is this a normal cyst? We have here some calcification, and here and here. So let's look at what happens when we do our contrast enhanced ultrasound. And you see small cystic infiltrations around this cyst and also around this calcification. And this is a alveolar echinococcosis. And you can you can suspect, you can just look at these margins and look for the infiltration, and then of course you do a serology, and maybe this is the other part of the liver, looks like this. Strange. This is all alveolar echinococcosis, and because this patient had a surgical problem, they did a biopsy, and it's proven with a biopsy that this has been an alveolar echinococcosis. This is another patient with just one cyst and nothing else, and again you see small cystic infiltrations around this cyst. This is another case of alveolar echinococcosis. This is a hematoma in it's a cyst with a bleeding, and you see here this might be some solid tumor or solid part of the liver, but it's also hematoma. So you can distinguish this very clearly. And this is a cholecystitis with a perforation in the liver tissue. And of course, you can do contrast enhanced ultrasound, and you see very clearly where the abscesses are. And when you wait a little bit, you can also see that there is not only an abscess, you have also a metastasis here in this area. This is another abscess. You see, it's difficult to make your diagnosis when you see this grayscale sonography and when you have this typical enhancement of an early abscess. It's not a ripe abscess, it's an early abscess. You can say, yes, this is an abscess, and again you can do this kind of capture mode, and you see the huge enhancement around this abscess. So let me conclude. If we have a patient with a known malignant tumor, and on the other side with no known malignant tumor, we do with both situations, we do a grayscale sonography. When you want to characterize, we do a characterization of the detected focal liver lesions in patients with known malignant tumor, but we have to detect hidden focal liver lesions in the late phase. And in the other situations, when you have no known malignant tumor, you just do a characterization of detected focal liver lesions, and you use your arterial and late phase, of course, and here you mainly use your late phase. It's most important to detect focal liver lesions, especially when they are hidden, and then you do your washout, wash-in phase, and you can do your characterization of detected focal liver lesions. Thank you very much.